So, good morning, good evening, good afternoon, everyone. We welcome you to another conversation. Conversation with me, Mrigna Nagraj, and Pankaj Mehrotra. A conversation where we're delighted to talk to somebody who has been not only a person working in care industry, but somebody who is a managing director of an industry which is at home, which is working for people at home. So, giving the baton on to you, Pankaj.
Thank you, Dr. Mrigna. It's a pleasure to be back. And today we have a very special guest. He is not only a guest, but a very dear friend of mine. Someone whose roots are in India, and his journey has taken him from Mumbai University to the University of Edinburgh. Krish has been a management student, and he has worked into multiple verticals, and finally he found his calling in the social care sector. He runs a successful home care agency in UK, and he is very passionate about elderly care and the entire aging process, and for which he is keen to contribute back to India, whether in terms of the learnings or in training or in kind of collaborating. So, welcome you, Krish. It's a pleasure to have
Thank you.
you,
Thank
and
you,
we really look
Pankaj.
forward
Thank you,
to a lot
Mrigna.
of learning from you today.
Absolutely. Very humbled. It's a pleasure to be here. Thank you for inviting me. Thank you.
So, coming to the right at home model in UK that you're following, Krish, I would be very curious. My first question to you would be, before we begin with all the details, talking about everything, you could briefly share your own journey. So that was something that really intrigued me because you were there from technology, then consulting, then leading to home care in UK. What inspired this particular transition that you went through from the technology to the care industry?
Okay, I think there's been a lot of personal experiences in a nutshell to put it across that way. But I think where the way this journey unfolded was in my recent well, not in recent, in my past life, one of my last roles that I was doing sort of was around elderly transport. It was a service operated by sort of the Mayor of London, part of Transport for London, which sort of provided door-to-door transport for the elderly and the less abled people in the communities around London. As part of that project, I think I came across a lot of care homes where we used to take groups of people for activities to the daycare centers, and I think there was an instant sort of calling, if you like. I said I fell in love with the sector. I love to see the way they worked with these, elderly residents. And as much as I was more from the transport side of things, I also, in the background, had a keen interest in sort of business. And I think that led me to look into franchising. And when I started looking at franchising, typically what everyone does when when the Western part of the world is look for the big brands like McDonald's, Subways, KFC, you immediately think of food as being that primary, business model that you want to follow. But having attended a lot of, franchise exhibitions and, care seminars and healthcare seminars, I think it was instant. It was an instant calling that I kind of decided that getting into care would be something of interest, something I'd enjoy doing, and unless you enjoy doing something, I think it's a bit pointless. For the sake of running a business, especially, and also personal experiences. I think within the family, we were going through a journey. I've had someone with multiple sclerosis, Alzheimer's, heart condition. It's all been there in the family. Dad went through cancer, uh, and I think all of those put together, it was a natural transition, I would say. And I think that's kind of helped me shape up the service as well to some extent. The way I deal with my workforce, the way we see our clients, the one-to-one relationship led service that we always promote. I think the backdrop has been my personal experiences, I would say, in a nutshell. Yeah.
Oh, uh, that's uh, that's amazing. And Krish, to be very honest, so many founders and so many guests who have come, something which I keep telling them is what connects all of us is probably their personal experience, which triggers the interest in that particular field. And from there, then
Hmm.
we realize the areas of improvement or the areas of further development. And
Absolutely.
I
Absolutely.
think that is where you give your best, because it is not exactly a 9 to 5 hour forced job which you have to do. It is
Sure.
something which you have
Sure.
to create for the larger cause.
Absolutely. And
So,
I've had carers come to my house. So we've had that in our own house. It's not, I'm not talking any distant family here. So we've had carers come into our own house. We've been through the journey, the hospital pathways of how you get discharged, how care is arranged. So I think when we first came across that, it was instant that, this can be done slightly differently. This can be done a bit better. And then obviously with my tech background and experience in sort of building robust systems, it kind of just flew naturally.
no, very true, very true. In fact, probably in the last 1 year, I would have spoken to around 8 to 10 founders, and at the same time, if you look at their profiles, the first thing they will either write or tell you is that when I needed care for my parents, I realized this was the gap, and this was something which was not available.
100%.
So
Yeah, yeah,
we
yeah.
have got into it, and these people are all tech people like you, or very very experienced professionals. So definitely it is there. So as an extension, Krish, my question would be: being an entrepreneur,
Yeah,
we understand, yes, UK is very highly socially developed in the elder care sector.
yeah.
But what are the kind of challenges what you face as a home care service provider in UK with respect to regulations, policies, guidelines, standards?
Sure. I mean, this is quite a common, question I get asked or I've been put forward to. I think uh, primarily, as it's regulated. Care is regulated here. So I think regulation and compliance, I would put it right at the top because, it's not something that you can instantly produce, right? If there's an inspection or if there's something happening, it's not something. It's a process you have to follow, and it has to be uh, embedded in the way you operate on a daily basis. So I think a regulation and compliance would be sort of my first pick when it comes into. I wouldn't call it a key challenge, but it is a big factor. A big factor. In terms of the more complex challenges, workforce. This goes with, I think, any part of the world, you'll get the same answer. Like be it the UK, be it India, be it Australia, Kenya, you name it. I think workforce is a major crisis within the sector. You have the retention rates, generally speaking, are quite low within the sector. Then you have funding pressures. I mean, this is specific to the UK because obviously there is the private model versus the funded model. So I think funding is another one I would put down as a challenge. And I think yeah, I think those are the key ones. But also there's also the rising complexities of illnesses and different conditions, and some conditions are funded, some are not. So there's a lot of complex funding requirements for clients. Again, that can be put alongside the funding pressures. But also the various medical conditions. Dementia is on the rise, as you can imagine. Another huge one is falls. You just have someone who's fully there mentally, but they have repeated falls back to back, and you know some of them it changes their life completely. One fall and that person is a different person after they're discharged from hospital. So I think that is again, I would say, one of the challenges, because you have a very easy care package, someone requiring companionship. Next morning the carer has gone there and they're on the floor, and because a lot of our clients live by themselves in the houses, they could have fallen down the stairs, it could be in their bedroom. Sometimes the uh, alarms are not activated which are in place, or they don't have the alarms because they were functioning quite normally till yesterday. They go into hospital next morning, which is already quite a delay, which has affected them in several ways you can't even imagine. When they get discharged, come back to their home environment, they're a different person. They need 4 times a day visits, double ups. They're bed bound potentially, with the moving and handling. So many other aspects to consider, which wasn't there just maybe 2 weeks ago when they were living independently. So I think that is another area which we find quite challenging, because then all of a sudden you have to account for that increased care need, and your workforce again has to be aligned to be able to deliver that. So I think, yeah, that is another one we feel that's quite challenging.
So continuing on the same lines, Krish,
Hmm.
since we are also like my organization, 50 Plus Assist, we are also at home service.
Oh,
And
nice.
I
Yeah.
can totally relate to you when you talk about these challenges. Then care can change from day to night. That's why I
Yeah.
always tell the people who come to us that we are a very dynamic service. We are not a box service because we know things change from day to night. And
Sure.
so does the
Absolutely.
care
Yeah.
needs to. We need to adapt
Yeah.
and we need to change and we need to do things better
Yeah.
that
It's a
way.
24/7
So
business. Absolutely. Yeah.
absolutely, we are into that. So does when we're talking about regulations, I know you know a little since your roots are in India, you know a little about the Indian markets and everything. So do you think regulations in this case do they improve the quality of the care, or they're creating like a more pressure on the entrepreneurs who are trying to work in the field?
Uh, So I wouldn't say so. If everyone's doing things the right way, I mean, in a nutshell, if everyone's doing things the right way, I don't think there's any negative to it. In fact, it is needed because it provides you a foundation of systems and what you need to adhere to. And I think if you have the right team in place, and you have all the way from the director to the carer, if you have the right team in place and the foundations are embedded correctly, then I don't see that as being a challenge. I think it is definitely a blessing to have regulatory standards and basically inspections that they currently do in place. Yeah, definitely.
So what does CQC exactly play the role as such? I understand,
So
besides the terminology, what exactly is the body of work?
So, I mean, as at the moment they're going through a lot of changes. So they used to have, key lines of inquiry. I think it's safe, effective, responsive, caring, and well led. I think those were the key domains. I mean, they still have those domains, active, but they're kind of changing their framework a bit. I think they're obviously under pressure, understaffed, under pressure. Uh, I think their fundamental is to ensure the safety criteria across the board is kind of being met. There's certain, there's a Social Care Act, and they want to ensure that providers are following the Social Care Act in terms of safe recruitment, safe onboarding, the DBA structures, making sure your staff at entry point level are sort of the perfect staff or the right staff who would fit into uh, the business of delivering elderly care. Because when it comes to home care, you're entering someone's private space. They could have no mental capacity. They're one to one with the stranger in their house. So I think fundamentally they're there to kind of protect basically people's rights, and stand up for good governance, and ensure the service is meeting all that it needs to meet.
So, in a nutshell, for our listeners, what we can say
Yeah,
is CQC, which stands for Care Quality Commission,
yeah,
is a regulatory body, something in India compared to the Social Welfare Department, who
right.
who regulates the quality control of various social care services. But
Yeah.
do they also develop the standards, or they just regulate it?
No, they have criteria. They have standards, of course they have. So I think they have the governance policy. They have several different policies which have to be, followed through. They have the safeguarding is a big one, for example, right? You got to ensure the safeguarding rules in place and people are following all of that. They have these ratings that they have to publish externally. They have the duty to inspect these services. A lot of them go unannounced. uh, they just turn up and they want to inspect your files, and all of that is spontaneous. There is no buying time when it comes to that, and then that sort of promotes care providers to be on their feet all the time. uh what else? They also have a lot of what you call evidence based. You have to show evidence for everything. It's not just that they have all these standards and regulations. You have to show how each one of them is being evidenced and it's constantly being delivered. So yeah, I think they do have standards and regulations
So
side
their
by side.
scope
Yeah.
is all over UK. It is not a specific.
It's not specific to home care, so they have different, obviously,
No, what I
verticals. So
meant
they
for
deal with,
geography wise, like India, you have this is a state subject, like housing and
yeah,
social welfare. So
yeah.
CQC is the central body for the entire of UK.
Central body for England and England only, because in
Okay.
Wales you have something similar called the Care Inspectorate. In Scotland you have something, and in Ireland you have something. So when it comes to the UK, CQC is predominantly dealing just with England, and it covers medical, primary care, hospitals, care homes, home care, independent clinics. So the list is quite vast. Anyone delivering sort of healthcare, basically, and care businesses. Yeah.
So, I mean, Krish, understanding from the other side of the picture, we are at the side of care managers or entrepreneurs who are doing it. Understanding from the side of the families, how important are these ratings and how transparent is the system when we talk about it?
Okay. So the system is quite transparent. I mean, inspections can be sometimes delayed. So sometimes you could have an inspection done in 2018, for example, and the care provider has been given, an outstanding rating. Between 2018 and 2024, there could have been a lot of changes within the culture, within the leadership, within the business in itself. So uh, to a great extent, it is managed because obviously where risks are identified, people would notify the CQC, or there'll be safeguarding, or there's also the local authorities which play a significant part because they're your kind of local mini CQC, if you like, because within them they have an adult and social care department who pretty much will be overseeing some elements of the safeguarding or anything relates to safety, basically. So if there is an issue within a business, I think they are the first ones to get involved. As much as the CQC oversees the whole delivery from sort of the perspective of the region of England. So coming back to your question, I think it is quite transparent because you have unannounced inspections. Staff have been trained to kind of report incidents, report any sort of mishaps that happen. And I think if they don't feel confident in contacting management, they have the right to contact the local authority or CQC. So it is quite transparent in that sense, and it also acts for care businesses. It's sort of a marketing tool as well. It acts as your marketing engine. A care provider that sort of has an outstanding rating, pretty much it is a given that they will get more inquiries. Families will consider them over some other providers who may not have a very fancy sort of a rating and a report summary. So I think, yeah, it does play a significant role. And sorry, I think I missed a bit of your question. Do you want to just go over that again? I'm not sure if I
Yeah,
caught the
so
whole
the
thing.
question was that how important is it for the family? So I think you answered the question very well that
A
these
reassurance
ratings
in a nutshell.
are
Yeah, it's
very,
the reassurance. Yeah.
it's a reassurance, and since they're so transparent, it can be trusted upon. So which
Yeah.
makes a lot of sense. So talking about the older adults or the seniors who are living in UK,
Yeah.
I was just curious to understand what do you think, in your opinion, what is the key services people are looking at? Like when we talk about let me give you a little lay of India. So when we talk about small towns, like say B towns, let's say
Yeah.
Chandigarh or places like that, companionship is not the key service people are looking at, right?
No.
So, but when we come to big towns like Delhi, Mumbai, companionship becomes our core service or the key service, we say. So
Yeah.
when we're talking about services like that in UK, what do you think? Is it more personal care, or is it companionship? It is rehab, or as we spoke about, maybe post-fall hospitalization or a care like that. What are the core services people are looking for?
I think again, because the funded model exists, there is a slight variance. So when it comes to the private model, I think a lot of people start off with companionship, and just helping with these minor daily tasks, personal care, breakfast, food preparation, things like that. So I think Within the funded model, they don't have the option. It has to be more of, when it gets to a stage that they can't manage. So I think that is a key difference. But overall speaking, it would be companionship is very popular. Then you have, dementia care, medication support, elements of personal care, complex care. And then it goes on to sort of end of life and palliative care. So I think it's quite a broad spectrum. But as a private care provider that we are, I think the majority that we see is dementia care and companionship, uh, stemming from loneliness and people being alone, and the families, have to move away. They want to, ensure their mom or dad is looked after, or there's someone at least popping in to check on them every day. So often companionship is a key starting point, but then a lot of the times that doesn't even go ahead because that's what the family wants. But when you do the assessment, you find out the client is not ready for care. So then there is a big gap until they actually need care. There's been several months past. By that time, the person's had a fall or they're deteriorated in some way because this key family member now is not checking on them every day or every other day. So I think, it starts off at companionship and general support around the house, but very often I think it is dementia or early signs of dementia, people who have not even been diagnosed. I think it sort of it starts from there. Those are the most popular ones. Yeah.
So, just as a further understanding, how expensive, as a ballpark figure, let's say, how expensive was or cheap is home care in UK? What would be the figures like?
Okay, so it's a mixed model here. So I think it would start off, if you want to go down to figures, the local authorities, some of them, I'm not sure how they do it, but they could be starting off at like 18, 19 pound an hour. Whereas in the private market, it could go all the way up to sort of 45 pound an hour. So I think it's a huge, huge variance. That is quite shocking. London, obviously being very competitive, is kind of somewhere sits in the middle. But if you go to the more rural areas or the more affluent rural areas, you could even find care providers charging up to £50 an hour when you have to incorporate travel and mileage and things like that. So a huge, huge stark difference. I mean, there is the Home Care Association that publishes a report every year saying this is what should be the minimum price for care, considering into the needs of every care business, considering quality compliance, considering that you're meeting all your obligations in terms of tax. But that is just guidance. It's not mandatory for care providers or local authorities or councils to follow that. So as much as that sits in the background, you still find care providers charging half of the amount of the recommended amount, which is quite worrying, I would say. Yeah.
So let's say on a monthly, because although I know I am stepping onto Mrigna's domain, but because I
Mhm.
was very interested to understand the price points. As a
Yeah.
monthly package, let's say, I'm
Yeah.
just trying to compare it with India. So if I have to
Yeah.
take a full time 24/7 caregiver, what would be
Yeah.
the ballpark figure for a 24/7
So,
support
okay. So
staff?
within the UK, the way the system is aligned, we normally go by weekly pricing. I mean, I can still give you the sort of figures for monthly. But typically speaking, a care package costs, I mean, for full time, when you say there's two models, so it could be the 12 hours where they need individual support or where they're not sleeping at night. They have, conditions that do not let them sleep at night, or they have sort of delirium and other such, symptoms. So that could be a very heavy needs care package. So if you look at that, that wouldn't sort of fit into the standard live-in care package. That would have to be 12 hours in the day, 12 hours in the night. Now, that typically could cost you anywhere in the region of sort of £600 a day. So you could do the math there yourself, a 12-hour package. I mean, even worst case scenario, let's call it like £250 for the 12 hours. That's £500 a day. So that's straight away, if you do the figures, that's about 3,500 a week. And that gets to, I mean, it gets to sort of crazy figures on a yearly basis that you could be talking 500,000. 40,000 a month. Figures like these are quite common. Quite common. I mean, weekly figures is something I can give you straight away, which is like, as I said, 3,500 for a 12 to 12 hour support. Live-in care would be a lot more cost effective, in the region about £1,500 a week. So that's sort of very different to 12 hours one-to-one support. But within that 1500, you do not get the person being able to support at night because they've done the day shift, if you like. So if the client needs support in the night, not saying the live-in care wouldn't assist, they would still assist, but after it becomes a regular pattern of them assisting, it then becomes a safety issue of them not being able to deliver care in the daytime. So before you know it, the package evolves and you have a live-in carer in place who does the daytime, and then you have something called a night carer or a waking night. I mean, there's again two types of night uh, care services. One is called a waking night, which is more one-to-one. The carer has to be present in the client's room, sitting on an armchair or a sofa. Or you then have the sleep-in night, wherein you can have the carer uh, in another part of the house. They're just present there. They potentially can even rest and fall asleep, but they will have maybe a radio or some sort of a communication device. Or if they're just in the next room, they just got to keep the doors open just to kind of be aware if the client needs support. Now, that is a lot cheaper. But again, if you combine that, coming back to your question, 24 hours care, it would work out to be about at least £4,000 a week. So you can again do the math and work out how that works into a yearly figure of like over 200,000. And then if you were to look at it on a monthly basis, again 18,000 a month. So yeah, it is quite a scary figure when you think. We have had clients who have lost their savings, completely depleted within a couple of years of commissioning care. You've had people who then have to release equity from their property. You have various different models to fund the care. Eventually, they have to lean on government funding. When all of that is depleted, then you have to rely on government funding. And there is a slight difference when it comes to home care and residential care in the UK. So when it comes to residential care, even the value of your house is taken into account. So potentially you could even lose your house if you were in residential care, whereas home care is not means tested. So you potentially can still hang on to your house and rely on government funding. Uh, yeah. So it is, yeah, stark difference in the various different models. Uh, yeah.
To be honest, somebody with less saving, it sounds really scary,
It
to
does.
be
It does.
very
I mean,
frank.
I was just talking to someone the other day, and we were not, yeah, we were just trying to sort of break. I mean, in a nutshell, if I was to obviously explain this, it's like public funding kind of supports the vulnerable people, and then private funding kind of supports choice and flexibility. I mean, as explicit as it sounds, I mean, that is sort of in a nutshell one statement, which is, the reality of kind of the situation in the UK.
No, I totally understand. And I think this really helps us to also have an insight on how systems work in UK. Also,
Yeah.
Krish, you have
Yeah.
been very familiar with the Indian system and you have
Yeah.
worked
Yeah.
with compliances and guidelines and everything across UK. So
Yeah.
now I would be on a stage where I would like to compare the two things. First,
Yeah.
what do you think are the strengths that you see in India as as a country that you feel that UK is lacking? Or on the other side, I also want you to tell us that what do you think are the strengths in UK that you see are lacking in India?
Okay, interesting. I think India is at a very interesting stage, in its senior care journey. I think there's growing demand, but I think the governance and sort of the workforce development, it's again the same patterns that we earlier discussed. I think they need to evolve quite quickly to sort of catch up. Training is a huge element. I think it all starts with the right training, and obviously you have to have a right model for carers to prosper. I think the opportunity, I think that India has. It's not to necessarily just copy the UK exactly, but I think it can adopt strong systems, early on, and maybe combine them with sort of India's cultural strengths and, around whatever requirements families and, communities have. Those things can't be compared because that is entirely different in India. The needs and the wants from the clients would be entirely different to, what it is in the UK. But I think in a nutshell, it would be, the regulation standardization, that is something that India uh, can adapt, from or adopt rather from the UK. Workforce training, academies is something that I was speaking to Pankaj the other day. That's something that would have, a good, as long as it's modeled correctly, I think that has a lot of potential. Uh, Coming back to, I think, things that lack, I think dementia awareness in India, there's a lot of work, Pankaj is doing, and I'm sure, that is of a lot of value to people in India. I think dementia awareness is still quite lacking. There's a lot of work to be done in that area. Uh, I think governance and documentation, as much as we may not need an exact, CQC model as such in India, I think you definitely need to have more in terms of governance, documentation. It not necessarily needs to be a national, it could be done at state level, because I think there are some states that may adapt or may be willing to explore that much quicker than another state. Because if you wait for something national, then I don't think it's ever going to happen. If you look at the UK sort of examples, like you have CQC here, Care Inspectorate in Scotland. Uh, I mean, every state in India is, I think, quite capable of having its individual mini NABH sort of or organization or you know, foundation, if that's the word that you can have. I think there is a lot of potential. And coming back to your early compliance question, Atal, I think there's a lot, safeguarding in India. I'm not sure how that kind of is reported, or not really reported. How is it even identified? Because I think that there's a lot of cultural mindset there as well, isn't there? So sometimes, safeguarding, as much as it's a big word, if you break it down, I think an understanding of what it entails at grassroots level, I think is quite important. uh, Coming to the UK, I think CQC being there does, or any other sort of regulator being there, does create pressure. But what it does, it creates structure and clarity, And I think that is coming back to that point. I think that would definitely be something that will be very beneficial in India, right? They have this, the framework gives sort of a clear benchmark, around safety, the key pillars that I talked about earlier: safety, effectiveness, leadership, And because those ratings are sort of published, it creates transparency. And because of that, it pushes organizations to, continuously improve, be on their feet all the time. So if that kind of mindset is something that can be, brought into the Indian framework or the Indian delivery of care, I think that will go a long way. And as India is evolving, the market is getting more mature. I think families and, decision makers in India who are the care receptors, I think they will be quite open to that. And in another 10 years, I think it will kind of be a requirement, I hope, that, you have some form of accountability, if that's the word, to safe delivery of care. Yeah. And I think the
No, I
other thing I did want to mention about, the tech enablement. I mean, even in UK, obviously, there's a lot tech enabled oversight. That is a huge thing in India. I know in people in India have their own proprietary softwares, and everyone is kind of at a different level with that. But as long as you have some sort of a requirement, you need to have a care plan. The care plan needs to be reviewed periodically. There have to be sign-offs. You have to get the family's input, the doctor's input. Once you have all of those fundamentals in place, I think the quality of care will just instantly rise, which will have a knock-on effect on, making care a career, which will eventually lead to staff retention and workforce problems. So I think it's all kind of interconnected, Uh, yeah, I think that's my take on the view. It's a very interesting market, and I've been eyeing it since the last 5 years, as Pankaj knows. But yeah, that's my 2 cents on it.
No, it is interesting, Krish, because if you see compliance due to non-compliance or no standards, any and everybody is entering the market, which is lowering the standard of care, which in fact is affecting the whole cycle. So people
Yeah.
before hiring, they are thinking about, oh, this is a kind of care I need, so I better ask my maid to help me, and
Mhm.
they are not understanding that certain care requires certain compliances, certain
Sure.
training, certain experiences, and it doesn't works out like that, and it lowers the bar even further. So it's a very vicious
Yes,
cycle we are stuck in. And I
absolutely.
totally understand when you're talking about this point of, that we adhering to the compliances, having some certain standard. Like, it is a very valid point that when we make care plans, like I do it for my organization,
Sure.
We make care plans, and we have a psychologist who makes an assessment, and a physical therapist who visits, makes an assessment, and we make a care plan and then discuss with the family. But yes, the family physician and the neuro and the other doctors should be weighed on this plan. They should be a
No,
part of it.
absolutely. Absolutely. I think the more stakeholders you have, the stronger the outcomes are for your client and for the person who's at the receiving end. And I think for
Correct.
someone without mental capacity, I mean, I'm saying it does apply to everyone, but for someone without mental capacity, it's paramount to have that sort of a rigid system in place because it's in their best interest. I mean, who else would vouch for them unless you have those sort of systems sort of embedded at every level. Coming back to your earlier point again, India, like I said, it doesn't need to copy sort of the Western counterparts because it's an interesting market. It's got a lot within itself. But what I really feel is it can actually leapfrog, by embedding governance. And when I say governance, it encompasses training, clinical governance, workforce management, all of that. So India can actually leapfrog, the Western counterparts by embedding governance and technology, from day one and having, a clear pathway to the care journey for the care receiver. Yeah,
So yeah, I
So,
think it is something which is in benefit for both the ones who are
absolutely.
receiving the care and the
Absolutely.
one who are giving it. I
That's it.
think
And the
that's
feedback would
so
come back to the company, right? I mean, if that company
correct.
or the care provider is delivering care in that pattern, I think it is I mean, it goes without saying that that company is only going to grow and be an example, and more people are going to follow, and before you know it, that could be a revolution. It could change things, at a big level, by following, the basics.
right. So between Krish and Mrigna, I have a question. Probably just an insight. That is our last question from my side. Is something which is not in the script as such. 15 years back, there was a discussion between the Indian government and the UK government to create systems where the Indian NRIs or the older people can come and stay in India in a assisted living facility or a retirement home, which is at par, obviously, with the developed countries.
Yeah,
And it would have been much more cheaper for both the countries to do it. But somehow the concept did not take off. To my understanding, it was primarily the state funding, because the state fund takes care of a lot of care over in UK, and also the insurance part, that
yeah.
what happens. But besides that, the infrastructure and the care and the training and part could have been taken care of. So what do you foresee? Is it possible that you can outsource people from UK to India for at least, let's say, for 8 9 months a year?
I think in small parts this is happening, but then again, it is to those individual countries where the person has their roots from. So I know,
Exactly.
there's a lot happening in Mauritius, strangely enough, which I recently found out, wherein they're creating a senior care community, and it is, attracting a lot of expats from sort of the Europe, not just the UK. But then these people have some roots in Mauritius, or they speak French, or they sort of trial that. So I don't know exact details, but I think that kind of worked in that example, and they're looking to scale that. But when it comes to the UK, I think it can generally start off by, like I said, people who have a background, like they have some connections in Gujarat, for example. They can have associations here that could be doing a bit of marketing and position that as a model, and they can give that a try, especially with the weather, family connections. There is a lot in common. uh, Coming to the general population, I think it is possible, but I'm not sure when, because medical tourism is already quite big in India, and people are starting to, make the effort to understand, especially for dentistry and other various conditions. So if it can be done there, I don't see why it can't be done, in care. But then you also got to remember the current age group. So for the baby bloomers, as they call it, this can be quite an opportunity. But the generation before that, I think for them it's not really an option. Uh, just due to the cultural mindset, and maybe they're just not well read. They don't know enough about India. So potentially there could be several different hubs, but I'm not sure if we're there yet at that stage. But it is definitely something that can be modeled in the future once India has that foundation of the clinical governance, things like a framework for the safe and effective delivery of care. And once all of that is in place, I think it automatically would attract, especially from a price point. Like I mentioned the figures earlier, uh, it's astronomical. The difference in prices is just is huge.
Correct.
So that would
No,
definitely
Pankaj,
be a point.
Chris, I also understand and agree to the same similar points, Pankaj. It is interesting. It's a good food for thought, to be very honest.
Yeah,
That India, we are very good with the markets. We are very good with a lot of things. The only things we are lacking is compliances. We are lacking in the whole structuralization of the senior care. So
yeah,
once
yeah,
those structures are in place, I think
yeah.
multiple models like this can work out. And I feel like
Absolutely.
Krish said, it's actually happening at a micro level. It is
Yeah,
happening. So those who have been living in Dubai all their life, once they
yeah.
realize, because we have such clients, by the way, we are working with
Oh,
many of
nice.
such clients that they have
Okay.
lived the whole life in Dubai, worked well, ran their businesses and everything. And now that it's time that they need care, they're settled in India. They have hired organization like ours to make sure they get good quality care. And I would say at 1/10 of the cost or even less, they're able to manage I would say, a very lavish lifestyle.
Oh, nice.
So, which in itself is very lucrative for a lot of seniors, especially
Absolutely.
now we see the second generation and the third generations there. And since these people, but like Chris said, the most important thing is they need to have some sort of roots in that place. So somebody who probably
Exactly. I think
hails
that's
from
at this
Delhi
point. Yeah.
can
Yeah.
come back to Delhi. Ones who hail from Gujarat can come back to Gujarat, but you cannot
Exactly.
expect like a native UK guy or
I
an
think, yeah, we are far.
Australian to come to
Yeah,
Gujarat and start living the dhokla and the khandwa life. They cannot.
absolutely.
That'll
I
not
think it
work
reminds me of
out.
the movie, the Great Marigold Hotel, right? I think, the
Yes.
family. I think, yeah, that would be amazing to become reality, which it can become in the future. But I think there's a lot of groundwork that needs to be put in place. I mean, marketing is different. The weather is an automatic marketing tip anyway for anybody. Like if you just say the weather and the different, the cultural aspect of it, it would be very exciting. It can in fact promote people's longer life, if you like, compared to sort of the minus degrees you face in Canada or in the UK in the winter months. So I think that is there, but I think yeah, it is quite a lot of groundwork to be done because
Or the
people who will be
extreme
coming there.
heated weather of the Middle East,
Absolutely.
on the other
Absolutely.
side.
Same thing. Yeah. So anyone coming to India, I think the service elements would be covered, but that's not what they're really after. They want more systems, they want the systems to be there in place. In a nutshell, I think that's how I would sum it. Yeah.
No, I
Because a
think
lot of case studies where I've seen is in America, a lot of them they go into cruise ships and just hang around for a couple of months there. So if you
Yeah.
can spend your golden years traveling
Absolutely.
the
I know someone
seas,
who's retired and living in a cruise ship, Pankaj, for that matter. They've retired, they've sold their house, and they just cruise. That
so
is, I know. I know. I've not that I know them personally, but I've read in the news here. There's couples that have sold all their belongings and assets, and they're just cruising in
just
a cruise
imagine.
ship.
So what I'm saying is here probably places like Goa, Kerala, and some other
Absolutely,
places. If you can have an arrangement with one of the companies in UK or probably with the CQC and the funding part of it, that people can come here for 6 8 months during the right weather and they get the same kind of a coverage, and then they
Yeah,
have the
yeah,
flexibility to move it. I think
yeah. I don't
that
know
kind of
other
a
parts of the
future would
world,
be
but yeah, sorry, I don't know about other parts of the world, but I was just going to say add that, in the UK, insurance doesn't cover care. So I think coming back to the funding, aspects, and again, local authorities, no matter how advanced India gets, I do not foresee local, especially when it's funded care. Privately funded, yes, of course, there's a market. But
correct.
when it comes to funded care, as much as it would save them money, I don't think we're
They'll
there yet,
give the
because it
money to
also
someone
leads to
else.
the pathways. It also, they would be, here there's a pathway. If anything goes wrong, they're going to going to get admitted to the NHS. So I think that is just too complex to set up in India with the Indian hospital systems, the different private, uh, hospitals
It's not
chains
like
that
a Sheraton
exist there.
membership that
Exactly,
the
exactly.
standards in UK are the same and India the standards are the same. You'll get the same
That's
quality.
it.
Yeah, I guess
That's
you're
it.
right.
That's it. But it is an
Yeah,
interesting point. I think there's a lot of potential for, people who fund their care privately to, leave the UK and live their golden years, in countries like India, not just India, maybe there's other opportunities elsewhere. Uh, but yeah, it is, I don't think it's something that can be put in
No, I'm
place
sure that timeshare of
anytime
aged
soon.
care is very not very far off.
Okay.
What
No,
you
yeah,
had
it is.
timeshare earlier for hotels, I'm
Yes,
sure these
exactly.
care home timeshares will soon come in,
Yeah,
I think.
it is slowly happening in medical tourism, I think, because there's this facility in Chennai that I came across, AIWO, I think it's called. I don't know how you pronounce it, or if that's an abbreviation, but I think they are doing complete health checks. They're selling packages in the UK, and other countries, I'm sure, in the West, Dubai, everywhere. Uh, and people are coming in there for 2 weeks. You even have a personal chef. So you have your room, you're doing morning to evening, you're being monitored. You have all sorts of assistive technology plugged into you. They're doing checks. You have one-to-one with your doctor once a day, a personalized chef to do your diet plan, and it is kind of an interesting concept, and that is doing well. They have a waiting list, so it's kind of and it's not cheap. From what I figured out, it was about 5 or 6 lakhs for a week or something to that effect. So it's not cheap, but it is picking up, and I'm sure there's opportunities, to do something with sort of care in a similar pattern. But I think uh, when it comes going back to dementia and mental capacity, I think those are kind of the bottlenecks I foresee, that wouldn't make the transition to that model that easy.
so I also personally think it's very well said that it's good till the time you can live in a cruise ship, but the moment you're
Yeah,
dependent, that is
yeah,
when the whole hell breaks loose, and that
that's
is
it.
when we are stuck with the realities of situations.
Yeah, and that can be
So
tackled to a certain extent once you have care as a vocation. I know it doesn't pay that well. I just compare it all the time to hospitality, like I was telling Pankaj when we met last time. Hospitality, as much as there is a bit of a retention issue there as well. But if you look at the five-star chains, their retention is not too bad because they have a model. You have a hospitality program that takes them through that. You have a career, and you are sort of in that system for a lot many years. So if there's something similar that can be done in care, it is done in nursing, obviously, but if it can be done in care, and we can financially model that it is on par with hospitality, then you're automatically having people who can choose between, do they go into a program dealing with hospitality management, or they go into care management. And if it can become a vocation, I mean, Frank Finn, or that sort of an example that I gave Pankaj last time, was a very, tiny example. That's just an academy. But on a bigger scale, if it can be sort of a university-led program related to care management, I think, and then those roles can transition into nursing or other healthcare aspects, venture, can open doors into hospital positions. So until that's done, I think it's going to be difficult. Yeah, but once that is done, I think there is a huge opportunity if that can be done. I know, Pankaj, I think you're in a similar uh, thought process as well, isn't it? If it can become a foundational degree and people can go on a 3-year course and obviously be compensated in comparison to hospitality. Because I don't know one person who's told me that they visited an Indian hotel and not been impressed right from the time that they arrive at the, at the lobby all the way till checkout. It is quite high in terms of service.
So, Krish, I think we are already at the end of our
Oh,
session.
yes.
Yes, yes, it's been an hour.
Sorry if I carried on or dragged on for too long. I'm not
No,
very used
absolutely
to
not. We
doing
would have
these
loved
sort of
continuing, but I think
podcasts.
there
Yeah,
is so much of knowledge which we are gaining, and the viewers are also learning from this. That sometimes it one guest, one session probably is not enough for the
not at
country,
all. Not at all.
and especially when someone is a hands-on approach like you, who's running setup like this in UK, and which is and India is growing into those kind of shoes. So we would love
Yeah,
to have you again on this session and probably come back with some new questions and some new queries as to
absolutely.
how we can take some innovative models across the country. So,
Yeah,
Krish, really thank you for coming on the show, and it was
absolutely. No,
a pleasure
pleasure.
to learn from your experience.
No, no. Thank you for
Thank you,
having me,
Krish.
Pankaj.
In
It's very
fact,
humbled. Thank you, and Mrigna.
thank you, Krish. In fact, it has been very valuable sharing, and for us to understand how the UK model works, it gave us a very hands-on insight, like Pankaj mentioned before. So, thank you to both of you, to Pankaj, my co-host, and Krish, for being on the show today. Thank you to our
Welcome.
viewers for joining us. Please follow us at Elderly Care India and 50 Plus Assist for more such expert discussions. See you in our next session, everyone. Bye bye for now.
Thank you,
Bye.
Krish.
Thank you.
Thank you. God
Thank
bless.
you. Bye bye.